लिंक भेजिए, क्योंकि वो जो IIT देहरादून से लोग रजिस्टर्ड कर चुके हैं, पहले कर चुके हैं, वो कह रहे हैं कि बार बार रजिस्ट्रेशन पे जा रहा है, लिंक पे नहीं जा रहा है ये।
अच्छा, ये जो लिंक मैंने भेजा था, ये लिंक
आपने सही किया, सही कहा है सर नित्या जी। आप जो लिंक भेज रहे हैं ना, इट इज गोइंग फॉर रजिस्ट्रेशन एवरी टाइम। या
हाँ,
ओके, सो रजिस्ट्रेशन उठा देते हैं।
हाँ, उठा दो,
हाँ।
रजिस्ट्रेशन उठा दो।
एक मिनट सर, इसको मैं लाइव करके देन आई एम कमिंग बैक।
आप मुझे भेज दो, मैं अपने ग्रुप में भेज देता हूँ।
यस सर।
अब कॉमन व्हाट्सएप ग्रुप में भी डाल दो।
यस,
नाइस टू हियर योर ऑडियो दिस टाइम। लास्ट टाइम आप म्यूट ही थे पूरा टाइम।
राइट मैम।
Yutata ma'am, good evening.
So we are starting webinar.
You are mute.
Okay.
Dr. Badal, you will be Hi, Dr. Badal, you will be conducting the quiz.
Good evening, ma'am. Yes, ma'am.
Good evening. हाँ, यहाँ पे Puneet and Lakshmi are there.
Yes, ma'am. I shared the questions with them, sir, ma'am.
नित्या जी कनेक्टिंग लिंक भेज दीजिए प्लीज।
हाँ जी सर।
फिर बाद में YouTube में चले जाएंगे, अभी तो 2 मिनट। Nice, it feels nice to see the winners.
You stay on, Sujata, please stay on. Yeah. Nitya ji, are you starting? You have.
Yeah, it is there. I have shared in the.
Share the screen. Share the screen.
Yeah.
So okay. So that we don't waste time for the webinar. Yeah. You say good evening, jo aap karte ho kar lo.
Yeah. Good evening, all the viewers are there, and we are on the 7th module of epilepsy. Welcome you all on behalf of Academy of Pediatric Neurology. And today, once again, that we are starting our session with the felicitation of the quiz qualifier for last evening. So let me take, I think, opportunity to share the slides of quiz qualifier. And
Dr. Kunju, Dr. Kunju will
Kunju sir.
Yes.
Yeah, Nitya ji, you can highlight the person.
Of the side.
Yes.
From institution of the Goa Medical College, Goa.
Thank you.
So,
thank you. Thank you very much.
Congratulations.
Thank you, sir.
Congratulations, Ashwin sir.
Yeah.
Thank you.
Congratulations.
Congratulations.
Thank you very much. Thank you.
Yeah. Next is
now we
Kunju
have
sir.
Narmadan in the category of pediatric neurology training. He is from CHC Vellore. Congratulations, Dr. Narmadan.
Thank you, sir.
Congratulations, madam.
Thank you, sir.
Yes.
Congratulations.
Thank you, ma'am. Thank you so much.
Congratulations.
Thank you, ma'am.
And then we have Arnab Samanta. Again, congratulations from Calcutta National Medical College. Again, in the category pediatric residents for the quiz competition winner. Congratulations, Arnab Samanta, once again.
I think he's getting the fourth.
He's the fourth time. Out of the sixth module, he has got the fourth time.
Fourth time.
Very good, very good.
Very comfortable.
Arnab, you want to be a pediatric neurologist?
Because he's only pediatric resident.
Yeah, but it's the fourth time he's getting it, sir. Yeah. So actually, all of your certificates will be mailed to you, and you will be getting your Amazon voucher on your WhatsApp. And all those who from the now we extended from 6 to 8 modules, so all from the 7 module winners, we will see who are the cumulative maximum scores. Will be called for a face-to-face quiz in the last time, which is going to be held 2 weeks from now, next week. Yeah.
Yeah. Thank you. Congratulations
to all
to
the
all.
co-joiners. And today, now we are starting our webinar parts are there. And
Did you show the slide in which the CV
Yes.
is there of Dr. Kunju? Let me
yes, sir.
introduce.
Yes, sir.
Yeah.
Yes, ma'am.
You can highlight the speaker.
Yes, sir.
Good evening, everyone. Welcome to the 7th webinar in this series of webinars. This was extended by 2 because we thought that because of popular demand, we felt the EEG, what the pediatrician should know, was not being covered. So today we'll be doing on that. I'm very happy to introduce Professor Kunju, who actually needs no introduction, and he's a stalwart of pediatric neurology in our country. He started the first department of pediatric neurology in Government Medical College, Trivandrum, and he is currently superannuated. After superannuation, he's been working tirelessly in the field of pediatric neurology, and with his help and efforts, when we had collectively combined efforts of all of us, headed by him, actually was leading when we got the MCI recognition for pediatric neurology in India. Dr. Kunju, welcome, sir. And
Okay. First of all, let me see whether. Okay. First of all, I must thank Dr. Shafali and the organizers, including Dr. Organizing this program. And we have today the sessions on EEG sessions for the pediatricians, and I think the first faculty is Dr.
Sir, Dr. Rajiv will introduce Dr. Neelu Desai, and then you can take over. You and Dr. Neelu.
Okay.
Thanks.
Dr. Rajiv, please.
Please introduce.
राजेश जी, आपका ऑडियो कम है थोड़ा.
अभी आवाज आ रही है?
या अभी आ रही है. या.
Dr. Neelu Desai is a consultant pediatric neurologist at PD Hinduja Hospital, Mumbai, India, and she has more than 15 years of experience in pediatric neurology and epilepsy. She has a special interest in complex epilepsy and neuroimmunology. She was trained at Grand Ormond Street Hospital, London, and BK Wadia Hospital, Mumbai.
राजीव सर, आवाज बहुत कम आ रहा है. राजीव सर,
Pardon?
या आवाज बहुत कम आ रहा है सर. जस्ट चेक इफ इट इज वर्किंग. सुनाई नहीं दे रहा है ठीक तरह से.
Okay. Dr. Neelu Desai is a consultant pediatric neurologist at PD Hinduja Hospital, Mumbai. She has more than 15 years of experience in pediatric neurology and epilepsy. She has a special interest in complex epilepsy and neuroimmunology. She has been trained at Great Ormond Street Hospital, London, and BK Wadia Hospital, Mumbai. She has more than 20 publications in peer-reviewed journals. And she is doing Marshall Fellowship ICH 2008 in pediatric neurology at Great Ormond Street Hospital for Children, London. So over to Dr. Neelu Desai.
Hi, good evening, everyone, and thank you for involving me in this program and inviting me for this. And hope we have a very interactive and useful session on EEG in pediatrics. And we have very good speakers also. And I think over to Dr. Kunju to introduce the first speaker. Dr. Kunju, would you want to introduce?
No problem. Okay, Dr. Puneet Jain. He is the pediatric neurologist from SICKIDS, and he is assistant professor of pediatrics at the University of Toronto. And he is we all know that he is very much involved in the pediatric neurology training programs, especially by the IGNA, and recently through the AOCN also. And he has done his fellowship in the pediatric neurology hospital for sick children in Toronto. And he has worked as a consultant pediatric neurologist in the Division of Pediatric Neurology, Department of Pediatrics, B.L. Kapoor Super Specialty Hospital, New Delhi. And he was assistant professor in the Department of Pediatrics, Lady Harding Medical College. And he has worked as a pediatric neurology resident in All India Institute of Medical Sciences also. I am happy that Dr. Puneet Jain will be presenting on the actually EEG basics, what the pediatricians need to know. Because we all know that because nowadays people are getting, all the pediatricians as well as even general practitioners or even Ayurvedic people are asking for EEG, and there are a lot of EEG centers everywhere because Indian EEG machines are very cheaper, and usually the EEG, the machine, the vendors, they themselves train people, and so everywhere there are EEGs are available, and they will get a report from an adult neurologist most of the time. And when an adult neurologist sees an EEG, because always the pediatric EEGs are abnormal for them. So what they will do is they will report as a safe manner all the EEGs as abnormal, so that it will be safer for them. And the pediatrician also will be happy because he got an abnormal EEG report, so he can start medication. So because of this poor reporting, poor interpretation, unwanted anti-convulsant treatment is started. So by training, at least to know the normal variants and the basics, a pediatric consultant will be able to understand the differences in a normal EEG and abnormal EEG and the normal variation. So I think Dr. Puneet will be able to discuss this aspect and highlight the very basics of EEG for the pediatricians. Dr. Puneet.
Thank you, Dr. Kunju, for a kind introduction. Let me first share my screen. Okay, can you see my main screen now? Can you see my main screen?
Yes, sir.
Yes, it is seen.
Okay, good evening, everyone. I would like to first thank Dr. Shefali Gulati and Indian Academy of Pediatrics for organizing these series of sessions, and Dr. Kunju and Dr. Desai for finding time to moderate these sessions. Today, I'm going to talk about basics of EEG, and this session is primarily focused towards practicing pediatricians, and also there will be something for young pediatric neurology trainees. This session will be followed by a session by Dr. Lakshmi Narayanan, who will then cover more basics of EEG reading. So in this talk, what I was asked to do was cover three important questions. The first one is when and when not to do EEGs, how to record EEGs, and how does a normal EEG look like. So depending on time, we'll try to cover whatever we can in this short session. So the first very important question which is there in front of pediatricians is when to and when not to do EEG. Let's start with a small case scenario. This is an 8-year-old boy with recent onset syncopal attacks. The primary physician ordered an EEG to rule out epilepsy. And well, EEG shows some left centrotemporal or Rolandic spikes. Do you think these two are related? Probably not. I wish the life was simple, that if you order an EEG, if it's an abnormal, it rules in epilepsy, and if normal, it rules out epilepsy. But unfortunately, life is not that simple. So we know that children with epilepsy, up to 50% of them can have normal EEGs. On the other hand, children without epilepsy, a small fraction of them, let's say 1 to 2%, can show actual epileptic abnormalities, as probably shown in the previous case. So the bottom line here is EEG is a clinical diagnosis. Epilepsy is a clinical diagnosis, and EEG should always be used as an aid to that clinical diagnosis, rather than rule in or rule out epilepsy diagnosis. Why is EEG normal in some patients with epilepsy? I think the most important reason there is sampling error. We know that epileptiform discharges may be intermittent. So if you consider EEG as a small photograph or a small video snapshot in the background of the brain activity movie, then obviously what's happening before this clip and what happens after this clip, obviously we cannot point to that. So there's always that element of sampling error whenever you're doing this kind of 20 or 30-minute spot EEG. Another important reason is if the seizure generating zone or the spike generating zone is small, then again, it will not show up on the scalp EEG. Based on experiments, we know that at least a cortical area of 6 centimeters square should be activated or should be abnormal. Then only it will produce a spike on scalp EEG. So if your focus is very tiny, then obviously it may not be strong enough to produce a spike on scalp EEG. Another common reason which may lead to a normal EEG in children with epilepsy is deep focus. So again, if the seizure generating focus is deep, like if, let's say if it's an insula, incingulate or insula, again, your yield on scalp EEG will be very limited. And then there's a long list of technical issues which can again lead to messed up EEG interpretations. Also, at the same time, we should remember that normal children can have sometimes abnormal EEGs. The best example, which is quoted in this scenario, is children who show Rolandic spikes. We know that 2 to 3% of normal school-age children can have these Rolandic spikes, but it doesn't mean that everyone will develop seizures or will develop epilepsy. Only approximately 5 to 10% of children who actually have these Rolandic spikes will ever have seizures. So again, the EEG findings should be interpreted with caution, should always be interpreted in the context of the clinical background. Let's move on to common indications of EEG in our common practice. The most common circumstance that we encounter is a child with first unprovoked seizure. But however, in endemic countries like India, where inflammatory granulomas are very common, especially north of India, neuroimaging often precedes EEG, but most of the Western countries where inflammatory granulomas are not that common, most commonly EEG is usually done as a first investigation in a child with first unprovoked seizures. So how does this EEG help? So this EEG might help to clarify if the child has a generalized or a focal seizure or an epilepsy. It also gives you a sense of the risk of seizure recurrence. So obviously, if a child with first unprovoked seizures has a very bad EEG, by bad I mean very frequent or abundant epileptiform discharges, you will know that the risk of seizure recurrence is very high, and you may just end up starting him on the first anti-seizure medication without waiting for a second unprovoked seizure. The second common scenario is a child with already a diagnosed epilepsy. So here again, EEG will help you to clarify the epilepsy syndrome, putting the clinical features and EEG together and see if the clinical EEG features fit into a specific epilepsy syndrome. If a child with epilepsy has any clinical change, any sudden increase in seizure frequency or new semiology of seizures have come up, or they show any kind of neurocognitive regression, again, EEG is helpful. EEG can also be helpful in monitoring treatment in certain subgroup of epilepsies. The prime examples in this category will include infantile spasms. Obviously, once you start the first line treatment for infantile spasms, you definitely want to repeat an EEG, usually within 2 weeks, to see if EEG has improved or not. So even if the child has clinically improved, the parents are not reporting any spasms, but if EEG still shows hypsarrhythmia, you frequently treat with second line treatment. The other indications include epileptic encephalopathy with CSWS and absence epilepsy, where you use actually EEG to monitor treatment in these cases. EEG is also commonly used before wean of anti-seizure medications. Usually 2 years is our standard timeline. It gives a good sense of risk of recurrence so that you can counsel the parents accordingly and give them their chances of recurrence once you have weaned off the medications. And obviously, pre-surgical evaluation in children who are possible epilepsy surgery candidates, that's an entirely different cohort of patients who benefit from EEG and video EEG. Other common scenarios where EEG would be useful are complex febrile seizures. although in my experience, if the child is back to his neurological baseline, examination is non-focal, the yield of a spot EEG in complex febrile seizures is very low. However, most of the institutions around the world do end up doing a spot EEG for these patients with complex febrile seizures. Apparent life-threatening events or bruise in infants, that's another indication for EEG, but obviously you need to rule out the cardiorespiratory and digestive causes, which are more common causes of such events rather than rushing to get an EEG in such children. Autism, that's a big controversial cohort of children, but EEG is only useful if they're actually having seizures or they show regression, especially if the regression is late. Most of the children with autism will have their classical regression around 1.5 to 2 years of age. So if a child with autism regresses at, let's say, at 5 years of age, then definitely that would be an indication for an EEG. EEG is also useful in any other kind of neuroregression, even in absence of seizures, especially if the initial neuroimaging is negative, is not helpful, and you're waiting for genetic and metabolic tests. So EEG can be used to rule out an ongoing epileptic encephalopathy, which may account for that neurocognitive decline. And obviously, any kind of paroxysmal events which you're not able to solve based on your detailed clinical history will again warrant a routine, especially a video EEG, to further characterize those events and see if these are epileptic or not. The indications of EEG in ICU are totally different. Here, the most important category of patients will be the patients who have refractory status epilepticus. An ongoing EEG, like a continuous EEG monitoring or a spot EEG, would help you to further titrate the anti-seizure medications. Encephalopathy with suspicion of electrographic seizures, or patients who are on prolonged neuromuscular blockage, especially if they have CNS insults like hypoxemia or ischemia, stroke, trauma, or metabolic encephalopathies. They will again qualify for an EEG just to rule out any ongoing electrographic status epilepticus or electrographic seizures. Again, ICU is a place where the patients have all kinds of paroxysmal movements, and sometimes it may be difficult to say whether these are epileptic or non-epileptic. The common examples being some clonic movements in the limbs or some eye deviations. So video EEG can be very helpful to characterize these movements and to see if these movements are seizures or not. In NICU, CFM monitors are very commonly used, and many a times CFM monitors may show these elevations for seizures. So again, EEG can be requested to further clarify these suspicious events on CFM monitors if the child is on CFM monitor in neonatal ICU especially. Now this slide is more important when not to do EEG. So obviously an EEG is not warranted in any child with simple febrile seizures, a child with autism but without any seizures. When you have clear non-epileptic events of infancy, like let's say breath holding spells or self-gratification, obviously you don't require EEG. In these scenarios, home videos are very useful, and always review or always ask parents to make these videos before rushing on to get a EEG. In other neurological paroxysmal events like syncope, headache, dizziness, vertigo, again, EEG has no role, especially as first-line investigation. And again, don't order EEG just as a follow-up in case of epilepsy. You should have a strong question for the EEG before ordering EEG in this cohort of patients. So once we know when to order an EEG, let's see how to record an EEG. So before we can record, we should know where to place our EEG electrodes. So EEG electrodes are placed according to the International 1020 system. It's a very standardized system which is adopted by most centers across the world. The four anatomical points which are important for this system are nasion and enion in the anteroposterior plane, and the preauricular points both left and right in the transverse plane. Once you have marked these anatomical landmarks, then the hard work of measuring begins. Obviously, you can end up attaching n number of electrodes depending on your question and requirement. But in routine EEG recording, we usually restrict to 19 electrodes. By convention, the electrodes on the left side are odd numbered, and the electrodes on the right side are all even numbered. So the first measurement that the tech takes is from nasion to enion, and depending on that distance, the electrode markings are then done at 10 and 20% intervals. So let's say if the distance between nasion and enion is 10 centimeter, then the electrode marking for FZ will be 3 centimeter from nasion, then 2 centimeter here, and so on and so forth. So this is the first plane which the EG tech usually measures. The second plane that the EG or second distance which the EG tech usually measures is between the preauricular points. And again, the markings for these electrodes happen at 10 and 20% intervals. So that's why the system is called 10-20 system. The third plane is usually the circumferential plane. And again, the electrode markings are put at 10% intervals. The next plane is bilateral parasagittal planes. So both FP1, F3, C3, P3 plane and FP2, F4, C4, P4 plane. Here, electrode markings are placed at 25% intervals. At the last, the plane which is done is transverse plane, both anterior to vertex and posterior to vertex. And again, here the electrode placements are done at 25% intervals. These are just not any random electrode placements. We know that from experiments by Jasper and Penfield in 1950s, when the electrodes are placed according to the international 10-20 system, they have a definite underlying anatomical basis, especially with respect to the central sulcus and sylvian fissure. So definitely this system, the standardized system, has underlying anatomical basis rather than just being whims and fancies of a particular center. Now, once we know where to place electrodes, the next step is choosing your electrodes. And research has shown that silver chloride electrodes have the best impedances. They're able to reproduce the brain waveforms in a better way as compared to other electrodes. Most EG labs will use silver electrodes with gold plating. Before placing electrodes, the skin is usually prepared or cleaned so that it reduces the impedance when you're recording the EEG. A number of standard skin prep gels are available, and new prep is one of the commonly used gels across centers. Once the area is cleaned up, the electrode cup is filled with a conductive paste, which again kind of reduces the impedance and improves your EEG recording. Again, the choice of this conductive paste varies with centers, and at our center, currently we are using the one which is provided by Nihan and Kodam. For more prolonged recordings, let's say like epilepsy monitoring unit or continuous EEG recordings, you might require special glues, something like a collodion, but again, they require additional logistics like compressed air and proper ventilation systems in EEG lab before you can actually employ those kind of special glues. Before I further discuss the details, I'll briefly discuss an important property of the EEG machine, which is called differential amplification. So basically, EEG machine has these multiple differential amplifiers, and what they do is they basically make a difference between the potentials recorded at two particular electrodes, and give us a difference between these two electrodes, and also amplify that signal. We know that the brain potentials are very small, so they need to be amplified before they are actually visualized on the EEG screen. And by convention, a negative waveform will appear as upward deflection on EEG screen, and a positive waveform will appear as downward deflection. So for an example, if electrode X has a potential of 5 microvolts and electrode Y has a potential of 3 microvolts, the difference here will be 2 microvolts, which is positive. Therefore, you will see a positive or a downward deflection on your EEG screen. Let's take this second pair of electrodes. So here the difference will be -2 microvolts, which is negative. So it will appear as an upward deflection on your EEG screen. This is another example just showing the difference here is -30 volts, and it will appear as upward deflection of -30 microvolts on your EEG screen. Now, once you have electrodes in place, the next step is arranging these electrodes in a sensible manner on your EEG screen so that they make some anatomical sense. So this is referred to as montage. So montage is just how you arrange electrodes on your EEG screen. So the most commonly used montage in clinical practice is AP longitudinal bipolar montage. Here, the shape of the montage is like a double banana. So it's also called a double banana montage. And here, I'll just briefly go through this montage. FP1 electrode is connected to F3 electrode, making an FP1 F3 channel. Then F3 to F3 channel, then F3 to C3 to form F3 C3 channel, C3 to P3, and then P3 to O1. So this forms the left parasagittal chain here. Similarly, you have the left temporal chain here. then the right parasagittal, and the right temporal chain. And the middle one will be the midline chain. And again, you have the option in the EEG machine to arrange these chains according to your preferences. But at our institute, we usually arrange them as left temporal chain followed by a right temporal chain, left parasagittal chain followed by right parasagittal chain, and then the midline chain. And again, these colors can be customized, and you can choose whatever colors you like. But again, at SickKids, we usually use blue color for left-sided channels and red color for right-sided channels. There are other different montages which can be used, like a referential montage, where each electrode is then paired up to a common reference electrode, and also transverse montage. I'll not go into details of these montages, but each montage have their own advantages and disadvantages. Now in neonates, where the skull size is smaller, we tend to use a more abbreviated version of this full 19 electrodes. We usually use abbreviated 11 electrode arrangement here. Here we usually skip these middle electrodes here. If you can see here, FP1 is directly paired with T3 rather than F7. So FP1 is paired with T3 to form FP1 T3 channel. Then T3 is paired to O1 to form T3 O1 channel. So here, that's how we create a left temporal, right temporal, left parasagittal, right parasagittal, and then the midline chains. And then the CFM is further abbreviated version of this neonatal montage. It's very commonly used in neonatal ICUs, and it's a good screening tool for neonates, for neonatologists rather than neurologists. Here, only 2 electrodes are used on either side of the hemisphere. So most commonly, or most CFM machines will use C3P3 on left side and C4P4 on the right side, creating a C3P3 channel and a C4P4 channel. That's the usual channel used in CFMs. But again, with the current CFM machines, you can optimize which channels you want to use in the CFM display, depending on the site of abnormality or site of expected seizures. But in general, neonatal seizures are most common in this area. That's why most of the centers end up using these standard C3P3 and C4P4 derivations. Okay, so now once we have electrodes in place, the montages have been formed. The next important thing is check for impedances. Impedances basically refer to how well the electrodes are recording, and impedance check should be done routinely at the onset of recording and before ending your recording, just to make sure or ensure that the quality of your recording was good. It's very easily done in the currently available EEG machines, and EEG machines usually flag off the electrodes which have poor impedances. So you can either reapply those electrodes or even regel those electrodes before starting your actual EEG recording. In general, the electrode impedances should be kept below 5 kilo ohms, but even 10 kilo ohms is kind of an acceptable for a routine EEG recording. There's again a long list of other technical standards for EEG recording. I'll not go into details. For interested people, they can refer to our recent article in Indian Journal of Pediatrics, but I'll focus on 2 important aspects here. One is the sampling rate. Sampling rate is basically refers how frequently the EEG machine kind of picks up the brain signals. So we want the sampling rate to be frequent enough so that it reproduces the brain waveform, which is more closer to the actual biological waveform. If your sampling rate is small or lower, then the waveform that it will reproduce on your EEG screens will be markedly different from the actual original biological waveform. So you need some basic sampling rate to reproduce the biological EEG waveform. So in general, for a spot EEG, we recommend a sampling rate of 256 Hertz. Obviously, depending on your requirements, you can increase the sampling rate. So let's say for an invasive or intracranial EEGs like stereo EEGs, the sampling rate will be somewhere around 2 kilohertz or 2000 Hertz. But at the same time, you should also realize that higher sampling rate means big file size. So you should have eye on your storage capacity as well. Another important thing to look is the monitor specifications or resolution. Obviously, if you have captured a good quality EEG image, but if your monitor is not good enough to display that image, then the purpose is defeated. Most of the currently available monitors have good resolution, but always keep an eye what's the resolution of your EEG monitor. And there are guidelines available both for horizontal and vertical resolution for your EEG monitor. if somebody is interested to study these minimal standards in details, there are guidelines available both from US and Canadian societies, and these are easily available in literature, and you can easily obtain online. Okay, so besides that, we can also use some additional electrodes, especially in centers who routinely deal with patients with epilepsy surgery patients. These electrodes can be subtemporal, midline, sphenoid, or T1 electrodes. Besides these, adding polygraphic channels are very useful. So in general, the recommendation is always use EKG and EMG in most of your recordings. Electrodes like EOG, respiratory belt, or saturation probe can be used in specific circumstances or case scenarios. So let me give you an example. So this is a 16-year-old boy who was admitted in ICU in tonic status. You see an AP longitudinal bipolar montage here, the EMG electrodes, the respiratory belt, and the EKG electrodes here. Well, you'll have to believe me that on EEG, I see a very classical signature of a tonic seizure. And let's see what happens. So EEG, the seizure has already started, but you don't see much on the video. So, sorry. So despite seizure being on EEG, you don't appreciate a lot on the video, but if you carefully look at the EMG electrodes, it's clearly picking up a subtle tonic seizure, which is not very apparent to your eyes. So in this case, EMG electrodes are very helpful in picking up this subtle tonic seizure. Another good example of how these additional electrodes help are neonates. So this is a term neonate. Again, you see your routine AP longitudinal bipolar montage, double banana montage, additional polygraphic electrodes here, EMG, respiratory belt, and EKG. So this was a term infant with no perinatal asphyxia or stroke who presented with seizures on day 1 of life. And these seizures were both left clonic, right clonic, and also apneic events. Because of the apneic events, we also added additional polygraphic channels. So if here you can see the saturation probe and also the pulse rate probe here. So let's see what happens here. So here on the EEG, you see this ictal onset from the left temporal region, and you see this respiratory belt suddenly flattening out with the seizure onset. At the same, sorry, it started again. Yes. At the same time, you also see the heart rate, which is in hundreds, start to decline. So heart rate going up to 65, 66 in this seizure. And finally, the bedside monitors start beeping because of relative bradycardia, and then the bedside nurse comes to his rescue. So again, these polygraphic channels are very useful, especially for neonates, where it's very difficult to pick up these subtle seizures. Besides EEG electrodes, the other important thing is EEG sedation. Most of the time, try to avoid sedation if possible, but if required, the commonly used agents are chlorohydrate and melatonin, and you should always make a note of these agents before you start interpreting your EEG. The duration of EEG, at least the minimum which is recommended is 30 minutes for a routine EEG. For neonates, we tend to have a more prolonged recording to capture one sleep-wake cycle. So we usually recommend at least 1 hour for a routine neonatal EEG monitoring. Presence of the tech in room is very important. Most of the techs, they remain bedside. They keep on observing the patient, keeps on annotating whatever they're seeing, because sometimes videos may not be very clear. And these tech annotations are very helpful when you're reviewing these EEGs. I'm not sure if I have another 10 minutes to review the basics of reading EEG. Is it already time for me, or I still have a few minutes?
Dr. Shefali, so how many minutes we can give to Dr. Puneet? We can just take how many slides?
I'll maybe 10 more slides, but these are mostly examples. I'll try to go through them quickly. Okay, so once we have placed our electrodes, the next is reading the EEGs, which is also a difficult task. So before you get started, the important thing to note is age of the patient, which is very important while you interpret the EEG. You should be aware of all the milestones, especially in the pediatric EEGs. Gestational EEGs, gestational age is again very important once you are interpreting the neonatal EEGs, because we know that the neonatal EEGs change remarkably with each advancing gestational week. State of the patient is important, whether he's asleep, awake, drowsy, comatose. So again, those kind of information is very important before you embark on reading the EEGs. Always note what anti-seizure medications he's on before you start reading, and also all the sedation which the children has received before the EEG. And obviously there has to be a technical checklist which you should again make sure which it's all correct before you start reading the EEGs. So the first thing that you see is whether your filter settings are correct. So always look at your frequency filters. So LFF refers to low frequency filter. Most labs usually keep it at around 0.5 to 1 Hertz. High frequency filters usually kept at around 70 Hertz for a sampling rate of 256 Hertz. Notch filter is usually off. Sensitivity, most of the time, the pediatric EEGs are read at 7 to 10 microvolts per millimeter of sensitivity. The paper speed or time base is usually kept at 30 millimeter per second, but obviously there'll be scenarios where you would like to stretch your paper speed to 60 millimeter per second, or for slower EEGs, even to 15 millimeter per second, especially for neonates. The other thing to note here is all the number of annotations which the tech has marked here. So you see these annotations: eye close, asleep, sucker soother. So all these annotations are very helpful while you are interpreting the EEGs to look for false EEG things, artifacts. So that's always very helpful. And also look at the additional channels which have been put here. So EMG channels and the EKG channels in this particular case. The basic EEG waveforms have 4 basic frequencies. The first one is the beta frequency, which is the fastest frequency, which is visible on the scalp EEG. It's usually more than 12 Hertz. The next band is the alpha frequency, which is 8 to 12 Hertz. Next band is theta, which is slower at 4 to 8 Hertz. And the slowest frequency, which we can see on scalp, is delta frequency at 1 to 3 Hertz. The most prominent rhythm that you see in a child who's awake, who's an older child, so here 14-year-old boy, is a posterior dominant rhythm. It's usually in the alpha band. So here you see approximately 10 Hertz frequency in the posterior derivations, so T501, T602, P301, and P402. So this is the posterior dominant rhythm. And we know that this magic figure of 8 Hertz is usually reached by 3 years of age. But the first time when you actually start seeing a posterior dominant rhythm is around 3 to 4 months of age, where it usually starts at around 4 Hertz. It gradually increases and reaches the magical figure of 8 Hertz by 3 years. And then it tends to flatten out by 10 to 11 years, where the more adult PDR of 10 to 11 Hertz is noted. So this is a 9-month-old showing of slower posterior dominant rhythm around 6 Hertz. And this is a 4-month-old showing even a slower posterior dominant rhythm, barely 3 Hertz. Okay, so again, you should be you should know the age of the child and gestational age of the child before you start interpreting these background features. Alpha rhythm also has a peculiar reactivity to eye opening and closing. So you see that this posterior dominant rhythm quickly comes up as soon as the eyes are closed, and also disappears or blocks when the eyes open here. Another important thing to look is the symmetry of the PDR. In general, the PDR needs to be symmetric on both the hemispheres. But if you see or look in this case, the PDR is clearly dominant or lateralized to right hemisphere. It's slightly attenuated over the left hemisphere, which probably correlates to this left hemispheric pathology that this child had. Another important frequency which you see, or rhythm which you see in an awake child, is the mu rhythm, which is again in the alpha band and it's prominently seen in C3 and C4. And this one blocks with contralateral hand movement as compared to eye opening in case of alpha rhythm. I will probably skip the continuity part, but with drowsiness, this alpha rhythm usually disappears, which is called an alpha dropout. and you start seeing this slow, roving eye movements, and also increase in diffuse beat activity, which may be exaggerated or exacerbated by the sedatives that the child has received. And with further deepening of sleep, you start seeing vortex waves in N1 sleep and then sleep spindles in N2 sleep. Rapid eye movement sleep or REM sleep is frequently not captured in a routine EEG, but frequently captured obviously in a prolonged video EEG recording. And similar to a wakefulness, however, child is asleep and EMG shows complete physiological atonia. And you frequently see these eye movement artifacts during REM sleep, which is a good marker to identify this kind of sleep. Before I end, I'll just briefly mention about the activation methods. So few activation methods are routinely a part of EEG recording, and these include hyperventilation and photic stimulation. But depending on your question for the EEG and the type of epilepsy you're looking at, you can also have additional activation methods like sleep deprivation, ASM withdrawal, especially if you want to see a seizure, special methods for various kinds of reflex epilepsies, which can be added to your routine hyperventilation and photic. I'll probably skip these slides and just conclude by saying that one should know an appropriate EEG indication before embarking on that. You should have a strong question for your EEG recording, just not as a follow-up to your clinical care. You should have a good quality EEG equipment, and EEG should be recorded by a trained EEG technologist following minimal quality standards. And obviously, given all the complexities in interpreting pediatric EEGs, EEG reader who is experienced in pediatric EEG should be the one who should be reading these EEGs. Thank you so much for your patience and time. Any questions?
Thank you, Puneet. That was a wonderful talk, and you have highlighted all the important points. And again, you have highlighted the importance of not doing EEG for conditions like syncope, febrile convulsions, etc. And all of you must know that when we do an EEG in an unwanted situation, as I have mentioned earlier, it's the reports may be misleading, and so the reading may be inadequate. Shall we? I think we'll be going to the next talk. Questions are allowed now.
Dr. Lakshmi Narayan.
Yeah.
Pardon?
Yeah, I think the next. Do we have the questions at the end, or I do not see any questions?
At the end, we can request people to please put their questions in the Q&A. Somebody's raised the hand. Please put the question in the Q&A.
Yeah. I think our next speaker is Dr. Lakshmi Narayanan from Chennai, from Lingales Global Health City. He is a very well-known pediatric neurologist who has trained from AIMS, New Delhi, and he has done MD Pediatrics as well as DM Pediatric Neurology from AIMS. Subsequently, he has also done fellowship in epilepsy and EEG from Royal Children's Hospital, Melbourne. He is a faculty at Asian Epilepsy Academy EEG course for neurologists in South Asia. And he holds a membership in ILE Epilepsy Zone Task Force. He's also a national convener for a Young Epilepsy Section and an executive board member of AOCM. His career interests are in drug refractory epilepsy, epilepsy surgery, and he has many publications in reputed journals. So over to Dr. Lakshmi Narayanan. He's going to speak on how to interpret. So we have seen the basics of EEG. But when a report comes to us, often we are not sure what does it mean. So as we know, we treat the patient and not the report. So it's important how to interpret the report. And his topic he's going to tell is EEG reports. What do they mean and how should we proceed subsequently? Over to you, Dr. Lakshmi Narayan.
Very good evening, everyone. Very good evening, the organizers. Especially, I would like to thank Dr. Shefali ma'am for inviting me and giving me the topic that is closer to my heart, that is talking on EEG reports. So we'll straight away go to the talk. So this slide is basically where Puneet left. So we didn't share our notes, but this is how it is. So how to get the maximum out of EEGs. So what he mentioned is a very good quality EEG machines, that is very important, as well as properly recorded EEG by well qualified and trained EEG technician. Of course, the pediatric EEG should be reported by those neurologists who have a very worst experience in pediatric EEGs. Why this is most important is EEG interpretation is very subjective as well as very operator dependent. So these three factors should be kept in mind whenever you come across any EEG reports. So what all can go wrong? Many things can go wrong. So the most common problems that we face in pediatric EEGs, especially those were reported by not so well-versed pediatric EEG experts. So in adult EEGs, basically the sleep markers are very flat. On the other hand, the pediatric EEGs show very tall, very angry looking, very high amplitude waveforms that are usually normal sleep waves, what we call K complexes and vertex sharp transients. But many times these are reported as abnormal, as Dr. Kunju sir annotated earlier on. Second most problem is the benign variants. So these are called benign epileptiform variants, though these appear like epileptiform discharges, but these are benign variants. The common one that I have shown in this example is hypnagogic hypersynchrony. So this can be again interpreted as a generalized epileptiform abnormality. The third one is the artifacts. Most of our kids are very not very they're a bit moving and fidgety and hyperactive, so you can have a lot of different kinds of artifacts, so that can be easily mistaken for epileptiform abnormality. So the common errors in interpreting pediatric EEGs are the sleep transients that are mistaken as abnormal, benign EEG variants misclassified as abnormal, or sharply contoured waves that are misinterpreted. So coming to what is interictal epileptiform discharge. This is the most common abnormality that we are going to have in the EEGs, and that is what we are interested in also. So these are basically called as spikes. So these are electrophysiological signature of an epileptogenic brain, most commonly noted in people with epilepsy. Rarely this can be seen in normal population also. This is considered to be a biomarker of epileptic brain, and these are, as name suggests, interictal. That is, these occur in between seizures. So the presence of interictal epileptiform discharges per se do not mean these are seizures ongoing. So this only means that this brain is more prevalent to having seizures than a normal brain. So these are some of the different types of morphology of spikes and shock waves that we commonly come across. And this is one example EEG where I have marked with round circles. These are the interictal epileptiform discharges. These are not seizures per se, but these indicate the tendency of the child or the patient to have seizures. So this is one just a model report that I have shown. So you have a patient demographic details, then you have how the record is done, how long the record has been done, medications what the patient is already on. Then we describe the findings. Usually we describe the background activity, awake and sleep. Later we describe the abnormalities. And the final part is the one that I'm going to concentrate more on this talk for next 20 minutes, interpretation of EEG. So in an ideal EEG report, what are the components? We classify the EEG as normal or abnormal, first and foremost. That is very, very important. So for you to know whether it is a normal EEG or abnormal EEG, you have to look at the section on comment or interpretation or the summary. Then we summarize the EEG findings, and we interpret the EEG findings because we don't expect the pediatricians to or physicians to interpret the EEG findings. So we provide classification as normal or abnormal EEG. We summarize the findings, we interpret the EEG for you. In some of the very good quality EEG reading centers, you get some recommendation also, but this is optional. Sometimes we ask you to repeat EEG if sleep has not been recorded, or if there is a need to correlate with the brain imaging, that we recommend sometimes, and some of the treatment implication can also be recommended. So first three are most important parts. The fourth one is optional. So I've again gone back to the same model report. In that first, the interpretation first circle marks it is abnormal EEG, and we usually say whether it's abnormal awake and sleep EEG, or it's only awake EEG, or it's only sleep EEG. That's very important. So that is where you will get that information. Then generalized 3 Hz spike wave discharges, that is the summary EEG finding, the most prominent finding that has been there. And what does it mean? It means the patient has a childhood absence epilepsy. So that is the interpretation of the finding. So this is a good quality EEG report, and this is what you expect. But most of the times you may not get this kind of a very detailed report. So I give you a scenario, 8-year-old girl with recent left-sided focal seizures at midnight. Neurologically, she has been normal. So this particular EEG was reported as normal awake EEG. Sleep, they tried, they could not get sleep. This is very common in an 8-year-old child. They may not go to sleep in the EEG lab. Despite the oral sedation, this child did not sleep. So kindly correlate clinically. So this is still, they have tried sleep, but could not be done. So that is important. Or you can get just like a normal EEG, that's all. And you have to assume many things there. And in a ideal setting, we would have this kind of a reporting. So normal awake EEG in this context does not rule out epilepsy, because we are talking about a child who has a left-sided phase seizure at night. We know that this is a most commonly scenario of benign Rolandic epilepsy. So a normal EEG in this setting will never rule out epilepsy. And I've given another comment also. Clinical details might indicate Rolandic epilepsy and repeat sleep deprived, awake and sleep EEG if the seizures are recurring. So this is ideal, but we don't get ideal reports all the time. Coming to case scenarios, 5-year-old child with a speech delay. He presented to the ER in the middle of the night with repeated vomitings. Mother thought it was due to the dinner that he had with fish, and mother thought it was indigestion. So the ER physician got carried away and diagnosed AGE with dehydration and given IV fluid. Blood investigations were normal and discharged 2 days later, only to present after 6 months again to the ER. This time the different ER doctor took a detailed history. What happens, why this repeated vomiting were there, and what happens in between the vomiting. That is the most important part. The mother came out with a history of unresponsiveness and eye deviation during these 10 minutes period in between the multiple vomiting. So he was admitted with an impression of nocturnal seizure loaded with levetiracetam, and awake EEG done next morning was normal. The child underwent the MRI brain because the child had a speech delay. So that was again normal. So what is the diagnosis? Clinical diagnosis is the most important. So nocturnal seizure was diagnosed, but this is a very important syndrome that we need to realize and recognize at the ER level. Most of these patients will present to ER, emergency room, in the middle of the night, early morning hours. So this is one very typical, very prevalent epilepsy in a young child. This is benign occipital epilepsy, what is called as Panaytopoulou syndrome. So this is very, very important for us to diagnose. Why that is important? Because we will not be just happy with awake normal EEG. We need to do a very good sleep EEG. In that, you will get a very repetitive, the blue line there shows repetitive spikes there in the right occipital region. This is a very typical finding that you will see in a child with another page of the same EEG. This is benign occipital epilepsy. So don't just stop with normal EEG whenever you think of benign focal epilepsy, because good sleep EEG is critical in diagnosing nocturnal epilepsy. Recognition of benign focal epilepsy, both benign occipital as well as benign Rolandic epilepsy, is very, very important because it can avoid misdiagnosis. It can avoid unnecessary expensive investigations like MRI, especially if it need to be done under general anesthesia. That puts the child under a lot of risk for general anesthesia that can be avoided. Metabolic testing, genetic testing that need not be done unscrupulously in these patients, because we know all these will be normal. And it aids in the prognostication. That is most important. Many of the parents would ask, will my child outgrow the epilepsy? Will my child outgrow the seizure? If we rightly recognize these are benign occipital epilepsy or benign Rolandic epilepsy, you can say yes. Over time, over 3 or 4 years next, your child will outgrow the epilepsy. This is a child, a 4-year-old. So the child is sleeping in the video EEG room, and you can see the child eyes open and has a lip jerking to the left side of the face. So this is a very typical seizure. So she is aware. She is looking at the mother there, and then she's looking at the father while he was talking. So the child was awake, alert, aware, and having these unifocal phase seizures of the left side. So this is the typical history that you will get in a middle childhood, nocturnal or sleep seizures during nap time also. So this is a very typical Rolandic seizure, and you will get Rolandic spikes, what we call centrotemporal spikes. Here in the right side, blue channels, here there are central parietal spikes as well as temporal spikes in the right temporal region. So right centrotemporal spikes, left side phase clonic seizure. This is a very, very, very common epilepsy that we come across in middle childhood. So the comment in this EEG report was abnormal awake and sleep EEG showing focal epileptiform discharges in the right central temporal regions. The discharges having typical features of those seen in benign Rolandic epilepsy of childhood. So if you get this report back, what do you interpret? What do you get out of this report? So you have to diagnose this as a benign Rolandic epilepsy. That depends on the history, examination, as well as EEG findings. So it's an electroclinical diagnosis, and there is no need for brain scan. That is the single most important finding here that we need to understand. If it is a benign Rolandic epilepsy or benign occipital epilepsy, no need for any brain scan, and we have to reassure the parents, and general seizure advice is needed, and prognostication can be done. So recently, the ILAE classification calls this as a self-limiting pharmacoresponsive Rolandic epilepsy, though I continued with the older terminology of benign Rolandic epilepsy because it is well familiar. This terminology is very familiar to all the pediatricians. So we usually don't treat this in the first instance, or if there are only infrequent seizures, but if the seizures become more frequent, this child might need treatment with valproate or carbamazepine. So the learning point here is not all the epilepsies need treatment. We have diagnosed with the Rolandic epilepsy. It is only first seizure. So you don't treat, you just wait. Some of the children may have only one seizure. Other child may have infrequent seizure once in 6 months or 1 year. So we can wait and watch. The moment you diagnose, the moment EEG is abnormal, you need not jump and treat the child. So there are something called incidental finding on EEG also. Many of you have come across incidental findings on CT scan and MRI. We have incidental findings on EEG, and this is the most common incidental finding, centrotemporal spikes. Up to a 2 to 3% of normal school-going children can have this abnormality. But among them who have this abnormality, only 10%, that is 90% will not have any seizure, only 10% will manifest Rolandic epilepsy. So this is single most important feature to understand. So EEG can show incidental findings and treat the patient, not the EEG report. This is the single most important message that you might have to take away from my talk. So the presence of epileptiform discharges in EEG per se, is it diagnostic of epilepsy? This is another very important question many pediatricians ask me. The answer is no, very emphatic no, because there are many studies, though these are older studies, the old is gold. These studies show that up to 6% of normal school-going children can have centrotemporal spikes as part of their EEG, but they have never had seizures in the past. They will never go on to have seizures in the future. So there can be incidental findings. So just having abnormal EEG does not mean it is epilepsy. So we again come to the same point. Normal EEG does not rule out epilepsy. At the same time, abnormal EEG per se is not diagnostic of epilepsy. Another clinical scenario, 13-year-old boy with recent tonic-clonic seizure, 6 a.m. in the morning when getting up from sleep. There was history of absences for last 6 months. So the EEG was reported as abnormal awake EEG, showing generalized spike wave activity on an otherwise normal background. The findings are typical of genetic generalized epilepsy. So with this is one example of absent seizure. He is hyperventilating and become suddenly unresponsive. There was name calling, but he was not responding. So this is typical absent seizures, and this is what you will get when you record a EEG during absent seizure. This is called typical 3 Hz spike wave. This is another page during hyperventilation, typical 3 Hz spike wave that lasts for 4 or 5 seconds in this page. It can last for anywhere between 5 seconds to 20 seconds. So if you get the EEG report like this, genetic generalized epilepsy or idiopathic generalized epilepsy, so we have to check the history of myoclonus. Again, no need for any MRI, CT scan, because genetic generalized epilepsy, idiopathic generalized epilepsy, you expect brain scan to be normal. So we don't do brain scans for these patients. And there is a risk for recurrence of GTCS because he presented with the first GTCS with the 6 months history of absences. So this is juvenile absence epilepsy, and we would start the patient on valproate because of GTCS recurrence risk. If the same child had the first episode of seizure, but there was no history of absences or myoclonic jerks, and the EEG comes back as normal, so what happens next? So you have to, again, there was no specific diagnosis. You have to go over again the history, whether it's only seizure or anything else. So you can repeat a EEG with sleep deprivation, and If you are confident of seizure diagnosis, definitely you need to have a MRI of the scan, because normal EEG in this setting, if you have done the EEG properly, well recorded, well done hyperventilation and photic stimulation, that rules out genetic generalized epilepsy. So this can be a focal epilepsy. Then you have to do scanning and you can treat with medication appropriate for focal epilepsy. Coming to last bit, so 4-year-old child with staring episodes, especially noted in the kindergarten by the teacher, the absences are suspected. So the EEG comes back as showing generalized 3 Hz spike wave associated with clinical absences. So we diagnose with the childhood absence epilepsy. These children need to be treated with ethosuximide or valproate, and seizure advice, again, no need for brain scan, because childhood absence epilepsy is one of the genetic generalized epilepsy. Again, the MRI will be normal, so we usually don't do MRI for these two. So this is the last case scenario. Okay, that video is not going to function now. Fine. So basically, I'm going to show you an infant who is otherwise normal with salam spell, what we call infantile spasm. So the infantile spasms, most of you would have already seen a typical salam spell, or head drop attack, head falling forwards, flexor spasm. So this is the EEG that shows high amplitude spike, sharp wave, and very disorganized background activity. And you can see more of mountain-like very high amplitude spikes, especially posterior region with irregular chaotic background activity. So these pages are slightly more organized. So this is a hypsarrhythmia variant, and this is during awake. Again, you see a lot of activity there. So this is hypsarrhythmia for you, and this is during the cluster of epileptic spasms. This is a compressed EEG page. In that, you can see 3 epileptic spasms in those EEG correlates. So this is a child with infantile spasms for last 1 week. And the EEG comment is something like this: abnormal EEG showing modified hypsarrhythmia with 1 episode of cluster of infantile spasms was recorded and waking. Clinical and EEG findings confirm infantile spasms in the context of West syndrome. So this is a diagnosis of West syndrome. We have to manage very differently from all other epilepsy, because the protocol for this is entirely different. So there are standard protocols using ACTH injection or high dose oral prednisolone 40 mg per day. And etiology workup is very, very important here. You need MRI, metabolic testing, genetic testing as required. So to summarize, diagnosis of seizures and epilepsy is clinical. Very good quality EEG is of paramount importance to diagnose epilepsy as well as epilepsy syndromes. The EEG only supports the clinical diagnosis of epilepsy. Mind you, EEG is not a confirmatory test. Again, to emphasize, normal EEG does not rule out epilepsy. At the same time, abnormal EEG does not rule in epilepsy. So EEG should be used very judiciously and interpreted in the context. A clinician, the pediatrician, physician provide detailed clinical information to the neurologist who is interpreting the EEG. That will be very helpful, because without the clinical information, the EEG interpretation is incomplete. So pediatric EEGs should be interpreted by neurologists with who are well-versed in pediatric EEGs. And we always have to remember that we need to treat the patient, not the EEG report. And when in doubt, when the patient does not respond to your first anti-epileptic medications, it's always good to have a consultation with pediatric neurologists. With that, I conclude. Thank you for your patient listening.
Thank you, Dr. Lakshminarayanan, for an excellent, crisp overview of how to interpret pediatric EEG reports. You've highlighted not only about the clinical information which is required, and how to interpret it and how to manage. So which cases do not require MRI, based on the EEG report you may come to know, and which may require treatment, or what type of treatment. I think thank you for this excellent talk. Maybe we can take some questions. I can see Dr. Kunju, do you want to?
Dr. Nilu and Dr. Kunju, we can have, we'll have to wait for 5 minutes because a quiz comes in between. And,
okay.
So 5 minutes, we'll just let the Dr. Badal do the quiz. When they're collating the results, then you continue with your comments and Q&A.
Sure.
Yeah.
Thanks. Dr. Badan.
Good evening, everyone. So Nityaji, please, flash the slide of the. Yeah. So next slide. So the quiz, today's quiz is going to be based on the EEG which has been taught today, and it will also include the questions of the previous last 6 modules. So the general instructions for the quiz would be: you have to ensure a seamless internet connection, which should be fast. The qualifying candidates would be pediatric residents category, practicing pediatricians category, and pediatric neurology trainee categories. So as we have said, last 6 quiz already have happened. This is the last quiz, and we'll have a grand finale the next Sunday, in which the cumulative scores of all the participants would be taken into consideration, and 5 people from 2 categories, the pediatric resident categories and practicing pediatrician categories, would be chosen for the grand finale. The pediatric neurology trainees would not be considered for the grand finale. So a total 10 people would be chosen for the next quiz, which is going to be held next Sunday. Yeah, next slide. So for the people who have not attempted quiz previously, the platform is going to be a Firebox platform. There's nothing to be done. You have to just click the link when it will be available. And when Nityaji opens this link in the chat box, so you have to just open it, and first you have to attempt all those 15 questions which will appear as multiple choice questions, and only one answer is going to be correct. At the end, you need to enter your institution, your name, and the particulars which is required. So the most important amongst all the instructions would be that whenever you are entering your name at the end of the quiz, you have to prefix your name by either PG or PP or PN. PG stands for pediatric residents, pediatric PP stands for pediatric practitioners, and PN stands for pediatric neurology trainees. So do not forget to put your prefix as I have told. If you don't put it, we are not going to consider you for the prizes. This time we have not kept an image because many times it's very difficult to pick up, at least on EEG. Next slide. So Nityaji, you may put the link in the chat box.
Yeah, just 1 second, sir. Link is there in the chat box. You all can start there, and it is being shared in the YouTube also. So people who are viewing over YouTube, they can also take part in this quiz. Just clicking the link.
Nityaji, keep the slideshow of the quiz is open now. Till the time another 2-3 minutes are going to pass by.
Sir, time starts now?
Yeah.
Fine. So it is also available on YouTube. Anyone who is viewing over YouTube, you can appear for quiz from YouTube also. Please mention your name and the prefix. So this is the live participation, how it has started. So you see 52 participants are attempting that.
Nityaji, refresh the live participation.
Yes, sir. So the progress bar shows that how many questions have been attempted by how many participants are there.
So we are left with the last 30 seconds. Last 10 seconds. Nityaji, we can close the quiz now. It's time now to close the quiz.
Okay, sir.
And hand over the mics to Neelu ma'am.
So Neelu ma'am, over to you.
Hi. I think there's some questions in the chat box which I can see. All EEG frequencies in one recording. Mr. Pratap Rawat has asked, Dr. Pratap Rawat, whether you can see all EEG frequencies in one recording. Dr. Puneet, would you want to answer this question?
Sure. So the question means, can you see all EEG frequencies in a single recording? Okay. So I think yes. Yeah, so I think that's very commonly seen that we see all EEG frequency in a single recording. So let's say the alpha frequency is commonly seen more posteriorly in the, let's say, occipital and parietal regions or in the central regions as a mu rhythm. More slower frequency like theta frequency is commonly seen in more central or fronto-central regions. And beta frequency is commonly seen during drowsiness more anteriorly. And slowing delta frequency, sure, probably in N2 and N3 sleep, we would see some delta slowing in a normal EEG record. So yes, all frequencies can be seen in the single record, depends on the age of the patient, the state of the patient, and the medication that he's received.
Yeah, I think so. If we have acquired both sleep and awake record, it is chances that we can get all the frequencies in the same record. The next question is, if a child is seizure-free for a period for 2 years after starting treatment, and we do an EEG to plan taper, and if the EEG continues to show IEDs, what will be the plan for anti-seizure medications then? This is a very, very common scenario which all of us would encounter. Dr. Lakshmi, would you want to answer this?
Yes, ma'am. Yeah, that's a very important question, and it's a very commonly asked questions by the pediatricians. And where does it come from? Basically, the 2-year period comes from the benign epilepsies. Okay, so people tend to generalize this to all the epilepsies in childhood. That is not true. Usually, benign Rolandic epilepsy or benign occipital epilepsy, these once they are very active, requiring treatment, after 2 to 3 years, they tend to peter out and tend to go into a spontaneous remission. So our aim for those kind of benign epilepsies are to prevent frequent seizures or to prevent prolonged seizures, so that we treat them for 2 to 3 years. By the time we expect a natural remission, so we can taper and stop them. In those scenarios, especially centrotemporal spikes, benign Rolandic epilepsy, most of the times EEG will be continued to be abnormal till the time the child goes through puberty. By around 14, 15, 16 years, the EEG invariably becomes normal in all the children with the centrotemporal spikes. But if the patient has undergone clinical remission, seizure-free on treatment for 2 to 3 years, that is the time we would give a trial of anti-epileptic medication. So it is very tricky to get the EEG in these patients, seeing all those very active EEG in sleep, very frequent discharges. Many people tend to continue the anti-epileptic for many years, so that is not warranted. Having said that, in other epilepsies, for example, Dravet syndrome, for example, Lennox-Gastaut syndrome, these patients tend to have more prolonged epilepsies, and they would go on to require medication for longer period. So this 2-year or 3-year seizure freedom rule don't apply to them. Okay, so that is the single most important. So medication withdrawal depends on what epilepsy syndrome you are dealing with. Many of the epilepsy syndromes, which are catastrophic syndromes, which are severe epilepsies like Dravet, like Lennox-Gastaut, like Douce syndrome, these will require anti-epileptic medication for a slightly prolonged time, sometimes maybe 5 years, 7 years, 8 years also. Even after that, there is a seizure recurrence rate after medication withdrawal that is to the tune of 20 to 30%, the seizure recurrence rate. So there is no single answer to this. It depends on what type of epilepsy you are talking about. If it is benign epilepsy, yes, 2 to 3 years of seizure freedom, you can give a trial of medication. But the role of EEG at the end of this period is a little bit unclear. It needs a little bit expert touch. It will be difficult to generalize at the pediatrician level. On the other hand, if it is a childhood absence epilepsy, if the patient has gone into complete remission and EEG is completely normalized, even after 1 year, we can withdraw the medication. Childhood absence epilepsy, even after 1 year of complete clinical remission, complete normal EEG in a very well recorded EEG for 1 hour or 2 hours for that matter, we can safely withdraw the medication. Having said that, juvenile absence epilepsy, juvenile myoclonic epilepsy, they may need a longer term treatment. Some of the patients with juvenile myoclonic epilepsy may need a lifelong anti-epileptic medication because the recurrence rate in them after medication withdrawal is to the tune of 80%. So there is no single answer. It depends on what epilepsy you are talking about.
Yeah, thank you, Dr. Lakshmi. So this is a very, very individual case-based decision which neurologists would take in this case. The next question is, how do we decide what montage is best suited to record the EEG? Where would transverse montage be most useful? Dr. Puneet, would you like to answer that?
Yeah, so that's a good question. But technically, by default, most EEG machines will acquire the EEG data in a referential montage. Therefore, your selection of system reference is very important. But the beauty of digital EEG is with reference or montage reformatting, you can create any number of montages once the EEG data is acquired. So from this referential montage, you can create your bipolar, anteroposterior montage, transverse montage, and average montage, or whatever montage you want to make from this digital EEG data. So technically, the answer is referential montage. But while reviewing the EEG, the most commonly used montage is a AP bipolar montage, the double banana montage. We can use other montages like referential montages for viewing for specific purposes, like when you want to very clearly localize an epileptiform discharge, or you want to appreciate a tangential dipole, then referential montages are very useful. But again, the caveat here is if your referential montage is contaminated, then it will be all messed up referential viewing. But again, the beauty of digital EEG machine is you can always change your reference electrode in the referential montage. So if you think your reference is OZ and O1 is spiking, you can always change your reference to FZ or more anterior reference and then view the referential montage. Transverse montage, again, is very commonly used to characterize the end of chain phenomena, and also some centers use it specifically for various activities which are happening in the central or midline regions. So I think it depends on your preference, your comfort level, but every montage will have its own advantages and disadvantages.
Okay. Dr. Kunju, would you like to take the next question? In a child who presented with a status epilepticus. Yeah. Can you see the question?
Okay. You just read, no problem.
In a child who presented with a status epilepticus who received a loading dose of an anti-seizure medicine, when would be the ideal time to do an EEG with minimal effect of the medicine on the EEG? So this is another common scenario which is seen by all of us. Dr. Kunju, would you want to answer, or any of the panelists, any of the speakers?
Well, it is a speaker's realm. Let them answer.
Okay.
Yeah, Dr. Lakshmi.
Yeah, so this is a very important question for us to understand. See, post status epilepticus, the purpose of EEG is very important. If the patient has not waken up and continue to have a prolonged post-ictal drowsiness, profound drowsiness or altered sensorium, definitely you need an immediate EEG to rule out is there an ongoing non-convulsive status epilepticus or ongoing electrographic seizures that is not being recognized clinically. If that is the purpose, at the earliest, immediately is the answer, and you don't have to worry about drug effects at all. This means if the seizures are ongoing electrically, this means your medication treatment is not adequate. You need to load with more medication. You need to look at the other strategies to treat. So that is one. Second, if the patient has completely stopped seizing both clinically as well as electrographically, then you are looking at where is the seizure coming from, whether right hemisphere, left hemisphere, the localization part or the etiology part. What may be the reason, whether it is a localized phenomena, localized pathology, or a generalized pathology. These are some of the interpretations that we can get from the EEG. So post status epilepticus, the EEG shows diffuse slowing, then you can detect possibly there is a diffuse pathology, metabolic or other diffuse like meningitis or encephalitis going on. If there is a focal slowing, that is the most common finding that we would come across post status epilepticus. If there is a focal slowing, say for example from the right frontal lobe or frontal region, then you can interpret that as possibly the seizure that the status epilepticus arose from the right frontal region. Some patients you can get interictal spikes despite immediately post-ictally also. So the answer, simple answer should be at the earliest post status epilepticus, you should get a EEG. If you are not getting any spikes, only diffuse or focal slowing, we would tend to repeat the EEG after 4 to 6 weeks. At that time, all the immediate post-ictal changes or post-ictal slowing in the seizure region all would have resolved. And at that time, you will be able to see a very nice short wave or spike in any particular region. That is the region of your interest. That is the region of seizure focus. Then you can localize that and look at the MRI. In that region particularly, is there any small focal cortical dysplasia or any other lesion for that matter. So at the earliest, EEG should be done. We don't too much worry about medication effects on the EEG because these two are two different things. Despite the medication, you can have your findings. and depending on the findings, there are interpretations. So we don't worry about medication findings.
I think one more question is there significance of, did you answer that significance of background slowing in EEG? I think Dr. Puneet can answer.
Yeah, so I think if you see a background slowing, the important thing is whether it's a diffuse slowing, which implies more of a diffuse encephalopathy due to a non-specific cause, it's not etiology specific, or whether it's a focal slowing. Focal slowing obviously will be more pointing towards a focal structural pathology or a functional dysfunction there. So both focal and generalized slowing will have different interpretations. Okay,
I think one point always you have to remember is that whether the patient is sleeping or not, that you have to remember. Second, look at the age of the child also, because for example, if it is a less than 3-year-old and starting in the infancy, because many times you'll be having a slow wave. So these things you have to remember. Then if in a vague state or in a partially alert state, the slowing will have its own significance. As Dr. Puneet has mentioned, focal slowing definitely in an alert patient, you have to think of a structural lesion also. And one more question, I think it is again, you can answer. Which EEG is better in neonates, amplitude integrated EEG or conventional? I think you must be able to tell the differences in situations where you're doing these two types of EEGs.
So the question is amplitude integrated EEG, what is this?
Question is, which EEG is better in neonates, amplitude integrated EEG or conventional EEG?
So as I talked or told in the talk that amplitude integrated EEG or CFM, it's a very screening kind of a EEG procedure, and it's good in hands of the bedside neonatologists who are managing the neonate on day-to-day basis. So it's not definite. We know that there are a lot of false positives in CFM. So it has its own place as a screening test. And then conventional EEG has its own place in actually confirming those seizures and even subsequently, managing these neonatal seizures if found. So both have their own places, and both are interpreted mostly by different people. So CFM is usually the neonatologist tool, and conventional EEG is more in the hands of neurologists.
Because maybe to Dr. Lakshmi, Dr. Samir Kiro has answered, because 5-year-old child with MR and seizure, idiopathic occipital epilepsy versus symptomatic. Can you say a few comments about that?
Yeah. Before going to that question, I just wanted to emphasize for the previous question. The EEG, many times we need to understand that, especially for the pediatricians, the EEG is not etiology specific. Many of the findings in EEG are very, very, very non-specific. EEG has a very good sensitivity for spatio-temporal resolution, but etiology you won't be able to guess except in rare cases. Say, for example, CJD in adults, that is a very classical EEG, and SSPE in children, that's a very classical EEG. These are very rare examples that we can, the moment you look at the EEG, you will be able to say, yeah, this is the diagnosis. But most of the times, etiology won't be deducted from the EEG. That is the single most important finding that we need to look at. Whether it is a focal or generalized pathology, whether it is a epileptic or non-epileptic kind of pathology, these kind of interpretations we can make, not the etiology. Coming to the specific question about MRI is normal, whether it is a symptomatic focal epilepsy or benign occipital epilepsy. Especially in our country where neonatal hypoglycemia is very, very prevalent, we come across very often, weekly, many patients we come across with a neonatal hypoglycemic brain insult causing bilateral, almost symmetrical occipital gliosis. They present with many different types of seizures, most commonly with infantile spasms and Lennox-Gastaut type of seizures, but rarely they can present with focal, symptomatic focal epilepsy also. So any child who presents with benign occipital epilepsy, not the Panaytopoulos type, but the later type, there is another Gastaut type, the later onset variety of benign occipital epilepsy, that definitely needs differentiation from symptomatic focal epilepsy, because clinically or electrographically, there are very few signs that we will be able to categorically say this is a benign focal epilepsy. In the Gastaut type, the late onset occipital variety of benign occipital epilepsy. So we always, in that type, we always do MRI to rule out underlying occipital gliosis. because in our country, the hypoglycemic neonatal brain injury is very prevalent, and occipital gliosis is very common, both due to hypoxia as well as due to hypoglycemia. So in those kind of cases, definitely we need a MRI. But pennitopolous type, usually MRI is normal. That is why I emphasized for a child with pennitopolous syndrome, you don't need MRI.
Okay, I think that was the final question. I must say that it was a very good, wonderful presentation by Dr. Puneet Jain and Lakshmi Narayan. To conclude, for the common pediatricians, you must all know that because epilepsy is not diagnosed by EG, the diagnosis is by your clinical history. So you have to take the clinical history from the patient, because that many times pediatricians forget, because they don't ask the child what has happened, because many times syncope might have occurred, or a reflex anoxic seizure, or a pain-induced syncope, because child may be playing with a blade and the child might have injured, and that would have produced the syncope. But the child may not reveal it to the parents hearing the scolding, but they will reveal to the doctor. So ask the child, then the father or parents, as well as definitely as an eyewitness. And so that way you have to define the seizure type as well as the seizure syndrome. So EEG is only supporting. And second thing is that already Dr. Puneet has mentioned the situation where the EEG need not be done. For example, when you know that the patient has a syncope, then you go for an ECG, not EEG. And similarly, as I have already mentioned, because the state of the child, especially most of the EEGs in children may be taken in sleep only, because of either because of agitation or not because they are cooperative. Most of the time EEG will be taken in sleep. So sleep changes will be there. Second, because the skull is very thin, you get a very high amplitude EEGs. So sleep, if the child is in sleep, so you interpret in that way. So that means normal variations like the slowing itself, plus K complexes, vertex, sharp waves, hypnagogic hypersynchrony. All these variations will be interpreted as abnormal. Then again, you must remember that hyperventilation also can produce very high amplitude spikish activities. And again, look at the photic simulation, because all these things in the recordings, especially when you get a printout, it may not be written by the written by the technologists, because EEG technician must be reporting all these things and must be putting it in the pages. So these things also you have to see. So that means whether it is a photic drive. So photic simulation you can see in the top of the page or in the bottom as just lines. So you just note to that. And for pediatrician, just try to remember FP2, F8, T4, T6, O2. So if you remember that, that is the right temporal leads, which will be the connected to produce the double banana. So FP, if you remember FP2, F8, T4, T6, O2, then you can remember all the leads, because that is on the right side. Left side, it will be FP1, F7, T3, T5, O1. And then, then easily you can remember the central leads. It will be FZ, CZ, and PZ, and then F4, C4, P4. So it is easy. So always try to remember FP2, F8, T4, T6, O2. I think reporting, Dr. Lakshmi has highlighted the need of reporting in a correct manner. And always when you are reporting, look for an asymmetry. That is very, very important, so that you can pick up a focal origin. Because when it is generalized, it is easier to treat, but you have to identify the focality and look for it carefully. I think that will be the good reporting procedure.
There are a few more questions.
Dr. Neelu, you can conclude. Or
Yeah.
I think if, there is further some procedures that can be done. Okay, Dr. Neelu.
Yeah, there are a few more questions. I don't know how much time we can take them. Can we get frontal spikes in Rolandic epilepsy? Clinically, child has nocturnal seizures fitting into Rolandic seizures. Doctor, any of you, Dr. Puneet or Dr. Lakshmi, you can take.
I think the classical spikes that we see in the Rolandic epilepsy, or now it's called childhood epilepsy with centrotemporal spikes, is usually centrotemporal, but frequently these have frontal and parietal fields. But isolated frontal spikes in pure Rolandic epilepsy is rare, but we have to understand that these self-limited focal epilepsies of childhood have a very big spectrum, and Rolandic epilepsy or childhood epilepsy with centrotemporal spike is just one part of that spectrum. And many children can have these functional looking spikes on EEG in frontal, parietal areas with these nocturnal seizures. So possibly these children lie on that spectrum, but may not fit into the classical Rolandic spectrum, the Rolandic epilepsy.
Yeah, to expand on that, it's very important to note some of the patients with Rolandic epilepsy can have a benign occipital kind of EEG. You will have only occipital paroxysm. Clinically, they have Rolandic seizures. EEG wise only occipital paroxysm. On the other hand, patients with Panetopolis syndrome, they have only centrotemporal spikes on EEG. This is very well known, and this is a very interesting phenomena to expand on the spectrum of benign focal epilepsies. But isolated only frontal spikes not seen. But along with centrotemporal spikes, there can be some spikes that appear like a frontal spikes. That is very common.
I agree to that. I think in benign focal epilepsies, the EEG may be very, very widespread, but to get isolated frontal spikes in any of them is very odd. The next question is, what is modified hypsarrhythmia? I think you have covered a bit in it. And would you please mention when to do EEG or while management of infantile spasms with either injection ACTH or prednisolone?
Yeah, so there are 5 hypsarrhythmia variants. So people interchangeably call these hypsarrhythmia variants or modified hypsarrhythmia. The more appropriate terminology is hypsarrhythmia variants. That is the terminology used by Rockovi, who described these variants. Basically, classical hypsarrhythmia, you don't have any fixed focus. It will be everywhere, all over the place, multifocal spikes, especially bilaterally posteriorly. But in a modified hypsarrhythmia, you will have a burst suppression pattern. You will have intermittent high amplitude burst followed by attenuated pattern. That is the most common hypsarrhythmia variant that we come across. In some hypsarrhythmias, there can be good background organization, including the sleep spindles can be very much present. So that is another variant. The third variant is unilateral hypsarrhythmia, or what we call hemihypsarrhythmia. The fourth variant is fixed focus. Say, for example, the patient with hypsarrhythmia will show only right occipital continuous slowing and predominant spiking over the right occipital region. So all these are hypsarrhythmia variant. The one I showed was burst suppression variant. And EEG is a very important, most of the cases we don't treat EEG, but some of the exceptions are epileptic encephalopathy, including West syndrome infantile spasm, where you would like to treat the EEG also, even if the patient goes into clinical remission. Say, for example, you diagnose West syndrome, start with ACTH or oral prednisolone. After 2 weeks, most of the children go into remission within 4 or 5 days. Even after that, after 2 weeks of clinical remission, you need to get a EEG to decide the hypsarrhythmia, how much it has resolved. If there is no significant resolution of hypsarrhythmia, you need to modify the treatment. So this is one situation where we treat the EEG. After, if the hypsarrhythmia is significantly resolved, then you continue the medication and stop according to the protocol. Then you repeat the EEG after 3 months, or if there is a recurrence of spasm, or if there is a change in the seizure semiology. Many patients, they have infantile spasm, go into head drop attacks after a few months. So they evolve into Lennox-Gastaut syndrome. At that time, you repeat a EEG to see Lennox-Gastaut syndrome features, and the treatment may be titrated accordingly. So these are some of the indications when we have to do EEG in West syndrome.
Dr. Lakshmi, I had a question, like if a child on starting ACTH has complete seizure freedom, would you, and he's doing very well, would you still do a EEG at 2 weeks?
Yes, exactly. We need to do EEG because even though clinically there is a complete remission, many a time we won't know what is happening in the EEG. Many children in that such scenario will continue to have a ongoing hypsarrhythmia that is worth treating with addition of vigabatrin or extending or increasing the dose of the ACTH or oral prednisolone. So usually we go for addition of vigabatrin along with steroids if there is a continued hypsarrhythmia at 2 weeks after the initiation of treatment. Because this is epileptic encephalopathy, how much ever you are able to normalize the EEG, if it is possible, then it is good for the long-term neurodevelopment. In some of the genetic cases, it may not be possible for you to normalize the EEG, but you can initially try up-titrate the medication and see the response in the EEG after 1 or 2 months.
Just add that in my experience, up to almost 30% of patients who had clinical remission continue to show hypsarrhythmia when we repeat EEG at 2 weeks. So it's very important to document resolution of hypsarrhythmia at 2-week EEG.
Do we need to stop AEG before EEG if it has been started for single unprovoked seizure, which is not confirmed clinically? Dr. Ashish Pradhan has asked.
Yeah, I think that's a very tricky situation and very common situation that we come across. So if your EEG is normal and if your history is not suggestive of a definite epileptic seizure, then obviously you need to have a frank discussion with the parents and tell them whatever you know and whatever you don't know. And after that discussion, it might be reasonable to stop anti-seizure medication, but with a close follow-up. But again, you have to be very
before if you're asking
honest
for
discussion.
an EEG. Sorry to interrupt. The question is, if you're asking for an EEG, do you need to stop AED before the EEG?
So it depends on the type of event. If, in your opinion, if you have a home video to review and if you strongly feel that that was not an epileptic seizure, then definitely you can stop the anti-seizure medication right away. But if you have some doubt about the description of the event or if videos are not available, then probably you might wait for the spot EEG before you make that decision.
Dr. Lakshmi?
So usually we don't stop any medication for routine EEG. So that is a simple answer. You don't stop anti-epileptic medication before ordering simple EEG. Because as I previously emphasized, we are not too much worried about anti-epileptic medication suppressing the spikes so that we won't get the yield. We are not bothered at all in the routine EEG. Okay, so we do the EEG despite the medication, and most of the times you will get the finding if it is there.
The last question, to measure amplitude of background activity, which montage should we use? That's a little vague question, but maybe you can answer.
I'll just simply put it that if you want to measure the amplitude of any activity, whether it's background activity, spikes or whatever, then referential montage is the most preferred montage. But again, the caveat here is your reference should be appropriate. Obviously, if your spike is occipital and if your reference is also parietal, then obviously you will get a falsely low amplitude. So with appropriate reference, referential montage is the best montage to measure amplitude of any EEG activity.
I think these are all the questions. Dr. Kunju, is there any other question at your end? And this is what I can see.
I think that is the only that much I think I'm seeing. Okay, let me see. Any other question is there? You childhood epilepsy, when do we repeat? This question have you asked in childhood epilepsy? When do we repeat EEG after starting valproate or ethosuximide? So after absence, when do you repeat epilepsy? Was that question answered?
No, it was not answered. In childhood absence epilepsy, when do we repeat EEG after starting valproate or ethosuximide?
Simple direct question. The direct answer to that is if the child has completely gone into remission, we do EEG after 1 or 2 months of initiation of medication, because again in this scenario, childhood absence epilepsy, as far as possible, it is better to normalize the EEG. This is another exception that where we do treat the EEG, because it has been shown the learning and other aspects can get affected if there is a unrecognized absences going on. Because if with the treatment, absences get very brief, 1 or 2 seconds, it cannot be clinically recognized. So we do EEG after 1 or 2 months, even after clinical remission. If there is no remission, there is no need for EEG. You can titrate the medication clinically. After 6 months to 1 year, if there is a complete remission, before stopping the medication, we would do EEG in childhood absence epilepsy.
That's it. When clinically when there is remission, otherwise there is no need for repeating the EEG, because the patient comes to you and you hyperventilate and see that there are attacks. Then there is no point in repeating EEG. Okay, I think anything else? Anybody else want?
Yeah. Dr. Neelu, before you conclude, Dr. Badal right answers, and then result will be out for today's quiz. Then you can give the concluding remarks. It'll just take 2 minutes for him to show the right answers.
Yeah, Nityaji, please
Dr. Badal.
flash the firebox.
Yeah, 1 minute, sir.
Yeah,
Yes,
so
sir.
we'll move on to the discussion of the questions we have asked in the quiz. Yeah, go ahead. So the first question was, what is not true about occipital intermittent rhythmic delta activity in absence epilepsy, which is called as OIDA? So the first option, rare in persons older than 15 years, is correct. Distinguished from posterior slow wave of youth, PSWI, by high voltage, that is again correct. Strongly associated with childhood absence epilepsy as compared to juvenile absence epilepsy, yes. OIDA has a poor prognosis. This is the answer which is to be marked because it has a good prognosis. Go ahead. Which amongst the intermittent rhythmic delta activity has maximum epileptogenic potential even without having interepileptiform discharges, interictal epileptiform discharges? So whether it is occipital, frontal, or temporal, the answer is temporal, which has the maximum epileptogenic potential without IEDs. Which is the intracellular correlate of the focal interictal epileptiform discharge as spike, which is seen in the EEG? The answer is paroxysmal depolarization shift, which happens because of the sodium conductance. Silverman anterior temporal electrodes for enhancing the yield in temporal lobe epilepsy of left side is. So we have read about most of the montages except this T1 and T2. We know that the T1 and T2 are taken for the increasing the yield of the temporal lobe epilepsies, wherein the left side would be the T1. The answer is T1. Electrocerebral inactivity, or the ECI, for brain death is measured when there is no EEG activity seen above. The answer is 2 microvolts. For that, we have to give the sensitivity at 2 microvolt per mm. What is not an abnormal response seen in EEG on specialized maneuvers or the activation procedures? So the photomyogenic response is a normal procedure, normal finding. It is not related to any epileptic form activity. So answer is photomyogenic response. Which montage is ideal to look at discharges arising from the electrodes with the end of chain phenomena? This is frontopolar and the occipital electrodes. So the answer is circumferential montage, or if you don't find circumferential, you can also write even the circumferential montage is the answer. Delta brush pattern in EEG is associated with which of the following? This is straightforward. We all know it's an NMDA encephalitis. Who recorded the first human EEG? It was Hansberger. What does the K stand for in K complexes, which are the markers of sleep markers in EEG? It is the knock. Comb-like EEG pattern is described in which metabolic disorder? It is the maple syrup urine disease, MSUD. A patient is seizure-free for more than 2 years and a repeat EEG is normal. What is the chance of recurrence after tapering AED? The answer is 25 to 30%. So the correct answer would be 30% in this scenario. All except which epileptogenic foci may be missed on a routine scalp EEG? Insula being deep, we will be missing it. Medial temporal, again we'll be missing it. Orbitofrontal, again we'll be missing it because we are not going to cover the surface electrodes. The answer is superior temporal, which can be picked up. Which of the following EEG findings would be associated with highest incidence of seizures? So if anybody knows about the benign epileptiform variants, the answer is very straightforward. Wicked spikes, mu rhythm, and 14 and 6 Hz positive spikes are called as the benign epileptiform variants. 3 Hz spike wave, we all know, is the hallmark of absence epilepsy. So answer is 3 Hz spike and wave. So we come to the last question. At what age does the children attain posterior predominant alpha rhythm as just like as in adults? The answer is 8 to 10 years. By approximately 8 to 10 years, the predominant alpha rhythm of approximately 10 Hz is reached. Thank you. So we can put on the slide for the winners. Nityaji?
Yes.
So amongst the winners, amongst the pediatric residents, it is Dr. Ankita from JLN Medical College, Ajmer. She has scored 73% marks. Amongst the pediatric practitioners, Dr. Ashwin Sardesai from Goa Medical College, 60% marks. And pediatric neurology trainees, Dr. Sridhar Joshi from CMC Vellore has scored 86%. So congratulations to all the winners, and see you all in the final grand finale quiz in the next week. Over to the
congratulations.
So
Congratulations to the
once again congratulations, because Ashwin the price, isn't it? Okay, bye. Okay, I think Dr. Shafali.
So you can, yeah, you can do any concluding messages you want to give. I just want to tell them that we have the last epilepsy module next week, which is on MRI and other investigations, and we have the grand finale quiz also in addition. And I'm really grateful to Dr. Puneet and Dr. Lakshmi for an excellent presentation, and thank you, sir. Dr. Kunju and Dr. Neelu for moderating. Can just give final messages, then we can wind up. Yeah.
Thank you, Dr. Puneet, Dr. Lakshmi. Excellent talks, wonderful quiz, good interaction, a lot of questions answered. And thank you, Dr. Shefali, for organizing such a nice meeting. I think we can end this session now.
Okay.
Thank you, Dr. Shafali, and Dr. Again now Dr. Puneet and Lakshmi, as well as the quiz presenters and the quiz winners. Thank you. Okay, good night.
Thank you. And
thank you, Kunju sir.
Thank you, Dr. Badal. Thank you, Nityaji.
Thank you, ma'am. Thank you,
thank you,
Puneet
ma'am.
sir
Thank you, everyone.
and Lakshmi sir. Good night to everyone.
Thank you, everyone.
Good night.